Welcome to the September 18th, 2025 PD Parlor with Dr. Priya Cardone of UPMC. She will be discussing deep brain stimulation. This is a first of three, I believe, in the series. Is that correct, Dr. Cardone?
It's going to end up being three because it's such a big topic.
Okay, thank you. And it's a little hard to hear you, but please take it away.
Okay. Can you hear me good now or not really?
That is better. Thanks.
All right. So, hi, everybody. Welcome. I'm really excited to do this lecture because DBS has been something that's grown on me since I've become an attending physician. It's really funny. Throughout fellowship, it was a very, very difficult concept for me to grasp. It just wasn't really going in my brain. It might have been because I was pregnant and the numbers were just not going in. After I had a baby, I had 3 months to stew about it, kind of, while I was technically unemployed. And then I started working here, and then it suddenly kind of clicked into place. And now I love it because I've been here for about the 4-year mark, which you'll see later in the presentation why that 4-year mark is significant. And then I have been able to kind of curate my own patients, and it's just different whenever they're your own patients rather than somebody else's patients that you don't really know them as well as your own. So I will, and I also have 2 guest speakers who are going to join us today from Boston Scientific and Medtronic. So they're going to show you a little bit of their own stuff too. So it's a little interesting of a lecture. So DBS is going to be like a really big topic. It's a surgical treatment option. So I've broken it down into kind of today, which is going to be the introduction to DBS, what happens before DBS, who can get DBS. The next session is going to be the actual procedure, the surgical, technical stuff, and then there's going to be a post-DBS. What do you do after the implants are in? Then what happens after that? So today we'll start with before DBS. So DBS means Deep Brain Stimulator Surgery. What is DBS? So if you're my patient, you've heard me say this, but it's still nice to hear. DBS is a surgical treatment option for the symptoms of Parkinson's disease. It involves 2 electrode wires that are inserted down into the brain, 1 or 2, typically 2. Those electrodes are then connected to wires that are tunneled under the skin, and they connect to a battery pack in the chest, kind of like a pacemaker battery pack. Those electrodes in the brain provide constant electrical stimulation to 1 or 2 specific spots within the brain that helps to control the symptoms of Parkinson's disease. Can everyone hear me all right also?
It's still a little hard to hear, Dr. Cardone.
To connect to the Jabra Speak 510, go to the Bluetooth menu on your smartphone and select it from the list.
Okay, is it a little better on this?
No, I think when you had the microphone, it was ideal.
I'll just hold it up. Is that
Yes.
better? Okay.
Yeah. And do you have a PowerPoint currently?
Yes. So
okay,
sorry.
we don't see that. So
okay, my screen.
Thank you.
Okay, here we go. Can you see my screen now?
Not yet.
How about now?
Maybe because I spotlighted you. Let me see here. Not yet.
Sorry. Oh, it says host disabled attendee screen sharing.
Oh, my apologies.
It's okay.
Not intentional. Just a moment.
It's okay, yeah.
Here.
I did it, Casey.
Oh.
Okay, there we go. Is that good?
Yeah.
Okay.
Yeah. Thank you.
Is that good?
Yes, and we can hear you.
Okay, very good. So yes, deep brain stimulator surgery is a surgical treatment option for the symptoms of Parkinson's disease. It involves 2 electrode wires that are placed down into the brain. Those electrodes, can you hear me? The electrodes are connected to wires that are tunneled underneath the skin, and that connects to this battery pack in the upper chest, similar to a pacemaker battery pack. These electrodes in the brain are stimulating either 1 or 2 different sites in the brain to help control the symptoms of Parkinson's disease. So there are 3 different brands for deep brain stimulator surgery. The 2 I chose to focus on are the ones that are most commonly used nowadays. So I have 2 people actually who are with us today, Chris from Boston Scientific and Adam from Medtronic. So I was planning to just let each of them take a turn to discuss a little bit about their own brand, maybe demonstrate and show some of the equipment. So let's see, how about, I think I see Chris on. Let's see.
Good, I'm here as well.
Okay, and Adam, okay. How about we start with Adam? I'm sorry. Oh no, I found Chris. It doesn't matter. Well, so we can just start with Adam. Casey, can you let, oh, Chris is already on. Can you let Chris be a host for a minute or something, or?
Yeah.
Thanks, Dr. Cardone. Thank you.
Hi, Chris.
I think we're seeing a screen within a screen, Dr. Cardone. So maybe if you could stop sharing your screen. Okay. And then go ahead, Chris.
Can you see my screen?
No.
I just see your name, Chris.
Okay.
Casey, did mine stop sharing?
Yes.
Okay.
I think, Christine, you might need to let Chris be co-host. I don't have that capability. Thanks for your patience.
I thought I did that. Yes. And I made Adam a co-host as well. So they're both ready to go.
Oh, great. Okay, we can see your presentation, Chris. But we can't hear you, Chris.
Can you hear me now?
Yes, however, we can't see your PowerPoint.
Let's see. From the beginning.
Okay, we can see your PowerPoint.
And can you hear me?
Yes.
Okay, perfect. Thank you, Dr. Cardone, for the introduction, and thank you for including Boston Scientific in your forum today for us to discuss the Boston Scientific DBS system. Again, my name is Chris Pappas. I'm a clinical specialist from the Pittsburgh area, and I've been with Boston Scientific DBS for nearly 7 years. Today, I will be providing some information on Boston Scientific's DBS system, which includes the implantable pulse generators or batteries, the DBS leads, and our programming software. First thing I'd like to take a look at are the DBS leads. So Boston Scientific has 4 options for DBS leads. We have a standard 8-contact linear lead, which is the top lead on this slide, an 8-contact directional lead, which is the second lead, and then new to the market are 2 16-contact directional leads. With these 4 options, that gives your DBS team the flexibility to choose what's best for each specific patient. When we talk about DBS leads, I'd like to mention this as well. So we have a couple of DBS studies, the Vantage and Intrepid study, a couple of registries that include more than 1,200 patients, over 2,400 leads. And we are proud to say that we have no lead breakages or fractures in all of those patients and leads. Second topic I'd like to touch on are the IPGs, or the batteries. So the battery is kind of what powers the entire system. Boston Scientific has 5 options for batteries. When we discuss batteries, we kind of break those into 2 categories. First category would be a primary cell. Second category would be a rechargeable. When we talk about primary cells, that is a battery that gets implanted and it will expire. under normal settings, those batteries last anywhere from 3 to 5 years. After your battery does expire, you have to come back for another procedure to replace that battery. When we talk about rechargeable batteries, we have two options. We have a 16-channel rechargeable and a 32-channel rechargeable. Those batteries are warranted for 15 years. So it kind of takes out the extra surgeries with the primary cell. Now, it is a rechargeable battery, so you do have to charge. Under normal settings, we recommend patients charge once a week, and usually the charge time is anywhere from 30 to 45 minutes. All of these options are MRI conditional. If you need to have an MRI, you can have an MRI done safely. One other topic I wanted to kind of touch on is our programming software. So Boston Scientific has kind of streamed toward what we call image-guided programming. We partnered with a neurosurgical imaging company named BrainLab. That partnership gave us the ability to view patient-specific imaging, specifically preoperative MRI and postoperative CTs. With the patient's specific preoperative MRI, we're able to perform what we call an anatomical segmentation. That gives us the ability to automatically visualize the patient-specific target that we're using for the DBS procedure. We're also able to visualize some structures around that target that, when stimulated, may cause some side effects. With the postoperative CT, we're able to visualize those DBS leads that have been implanted. And when we fuse that pre-op and postoperative CT together within this software, we're able to visualize exactly where that lead is within the patient's specific anatomy. So when we talk about image-guided programming, all of this information, once we fuse the imaging together, all of that information is taken into your neurologist's office. It is imported into their DBS programmer. So when you come in for your DBS programming, they're able to pull that up and visualize exactly where that DBS electrode is within your patient-specific anatomy. We have a number of different contacts and levels that we can stimulate from on this DBS lead. This gives the DBS programmer, your neurologist, the ability to visualize and save time. We've cited a specific clinical-based programming here that has 39 patients, and within that study, they determined that image-guided programming reduces programming time by about 56%. The latest advancement in image-guided programming. This is an AI automated programming. We call this Illumina 3D. Illumina 3D enables an easy and efficient DBS programming by automatically generating a patient-specific stimulation plan. What we're able to do is we're able to select a specific target area, your specific patient-specific anatomy. We're also able to select some avoidance regions if needed. When we do that, the software automatically, the algorithm generates a patient-specific stimulation plan for your patient-specific anatomy. Illumina 3D also has some steering controls that lets us deliver stimulation more efficiently and accurately. So what we're able to do is get to the correct spot a lot quicker than we have been in the past. That kind of covers the system a little bit. Couple other things I wanted to talk about. We talked about rechargeable batteries. So you have to recharge the battery. On this screen here, you can see we have a charger. It looks similar to like a hockey puck. We call it the charging puck. That puck is placed into a black collar that goes around your neck. You line that puck up with your battery and you start charging. As I mentioned earlier, we recommend charging once a week, and that would probably be for about 30 to 45 minutes. You can charge watching TV, reading a book, drinking a coffee, anywhere where you're somewhat stationary. One other peripheral I'd like to talk about is we have a remote control. So you will get your own personal remote control. With that remote control, you have the ability to check your battery level. The remote control will connect to the battery implanted in your chest. You can check the battery level. You can adjust your stimulation up and down, turn your stimulation on or off. You also have within that remote what we call MRI mode. We discussed MRIs earlier. You have the ability to put your device into MRI mode so you can have an MRI safely. I think that covers my presentation. Dr. Cardone wanted me to actually show the battery. So let me see if I can turn my video on. Stop sharing. And start the video. Sure if you can see me there or not.
We can see you.
Okay, great. So this this smaller battery here, that is the rechargeable battery. If I put it in my hand, you can kind of see how big it is there. I try to like kind of compare it to almost like an Oreo cookie. It's about the size of an Oreo cookie. This is the primary cell, much bigger. So when we talk about primary cells, that's a battery that needs to be replaced. So if we put those two together, you can kind of see the difference between the two there. And I think that's about it. Any questions?
I like the Oreo cookie. I've been using like cheese like on a deli tray, but Oreo is definitely more.
There you go. They're tasty.
Yes. Thank you so much, Chris. I appreciate everything. Does anyone have any specific questions for Chris? Okay. So Chris is from Boston Scientific, so I'm going to turn it over to Adam from Medtronic.
It's a little hard to hear you, Dr.
Oh,
Cardone.
sorry. Okay. So this was Chris. Thank you, Chris from Boston Scientific. Now we're going to turn it over to Adam from Medtronic. Can somebody help Adam become a co-host or share his screen or whatever?
Yeah, they actually have me as a co-host from my phone, but I'll need you to make me co-host from my computer as well, which is Matthews, Adam. All right, so it looks like I am now co-host as well. I'm going to share my screen and we'll chat through Medtronic. All right. So you see my screen now.
Yes.
Sweet. So I'm Adam Matthews with Medtronic. We're going to talk about everything Chris talked about, plus adaptive deep brain stimulation. I'm a DBS consultant with Medtronic. I lead a team of 9 engineers across the country who are devoted to the entire pathway of physiology and anatomy and programming, both on the development of the technology as well as the surgical side, the programming, and the data behind it. So I've been with Medtronic for 14 years. I'm in Michigan. Right now, I'm in a tropical smoothie in Ann Arbor because I go around and I do a lot of fun stuff with patients. Prior to Medtronic, I was a neurophysiologist working at University of Michigan. Yeah, so happy to be here. I love DBS so much. It's a big part of my life. So, all right, so Medtronic DBS, we're the originators, right? We started this with consultant physicians in France and beyond, and the first implants that we started to come out with were essentially stimulators, right? They have to bridge the gap between what can medications do and what the rest of the physiology accommodate for when programming with stimulation. So adding stimulation to medication, and halfway through there, like 15 years ago, 20 years ago, we started to research recording the brain activity. And this booted me out and then brought me back in. Can you hear me okay?
You had a brief pause.
Okay. Yeah. Interesting. All right. So the patient that created this graphic, her name was Sarah Ruggieri. She was a statistician, and she said essentially, we need better tools because you see me that this one dot, that's the neurological care that you see me, and all these other blue dots are the rest of my life living with my symptoms. And so we at Medtronic took that to heart, and we developed some recording mechanisms for looking at the information outside the clinic as well. So that's called brain sense. And as patients, you take your meds and you feel good, and then you feel off. The idea is DBS is to smooth these things out, give you more on time, less off time. And to do that, we set it up for stimulating at a certain level, and it takes some time to tweak it. We have a rechargeable and a non-rechargeable, just like Boston does, about the same size. And the idea is essentially, how do you program it to accommodate for those fluctuations? So you have medications, you're sleeping, you're moving. There's a treatment option with DBS that actually adjusts with your fluctuations outside the clinic. And that's called adaptive DBS. So the idea is we look at your brain signal, and you have a signal in your brain related to Parkinson's disease that is measurable. And our leads and our implantable devices were developed to actually measure these signals. We worked with our permanent implant. We developed it with NASA to essentially be as good as it can be for recording and stimulating at the same time. And so it's your physiology, your signal that's related to your Parkinson's disease is a certain frequency, kind of like a musical note. And we can measure that musical note. And when it gets louder, our stimulator can turn up stimulation. And when it gets softer, stimulation can be triggered to go down. And so as your medication levels go up and down, you can smooth out the fluctuations there by having stimulation go up and down. All right, so automatic adjustments, that's essentially what Medtronic is all about at this point in time. We've taken the conventional DBS system and work with our system to automate adjustments outside the clinic. So when you see your provider, they'll set it up, and then you can, if you need to have adaptive DBS, it's an option. You can use the conventional continuous DBS, and that works. It really works great for so many patients, but we can also turn on some automation. So these on and off times can be accommodated for with automation outside the clinic. Yeah, so the patients who were in the study, they preferred it. It's safe, it's effective. We have a couple different options for this. It's all software but enabled by the hardware. And so what Chris showed you already is essentially about an Oreo cookie, right? That's the idea of the neurostimulator. It could be the chest or the abdomen. The wire is about the size of a spaghetti noodle, and it does require a surgery, which is the bummer, but it really, really works. So the idea of kind of having a cruise control that adapts based on your distance to the car in front of you is one way of thinking about the therapy. The other way of thinking about this therapy option is a thermostat going up and down. When it gets too hot, the air kicks in. When it gets, and then it kind of cools off and it turns off. Same thing. That's kind of what we're doing with our therapy at this point. But we have rechargeable and recharge-free options, and that's what they look like. Not a ton of difference in terms of the actual hardware, just kind of what it does. So any questions or ideas about the hardware or what Medtronic DBS is all about at this point? All right. I love it. I love the silence because it means I've done a super good job, right? But also we we've devoted our lives. You know, Chris has been with Boston for 7 years, and I think he was doing other things around the space of neuro for longer than that. And uh, we all really care so much about our patients. So whoever, if you're thinking and considering this technology, this therapy really works, and we'd be happy to support you no matter who you choose.
Okay, thank you so much, Chris and Adam. I really appreciate your PowerPoints and explanations.
Go ahead and use your microphone again.
Sorry, keep reminding me. I'm not used to
Perfect.
that.
Thank you.
Thank you again, Chris and Adam, for your PowerPoints and your explanations. Very helpful and very useful for patients to be able to see the actual technology. So thank you for taking your time out of your day to join me today. All right, I will go back to my PowerPoint then. Okay.
Oh, it looks like Christine has a question while you're
Yeah.
doing that.
Hi, my question is more around the programming side. My understanding is that we don't really have enough people in our region to program and keep people in a good state on their device. And I guess the question is maybe for all three of you, Priya and Medtronic and Boston Scientific, what are you doing to increase the number of people who are available to help with programming?
We're teaching. So actually at my office, we have two APRNs, Justin and Heather. And yes, because of increased demand and increasing number of patients with DBS needing frequent visits, both of them have started to learn how to do programming. And Robert from Medtronic is the rep who's for our office. So he has been really nice and kind and helpful to teach and also guide them. And it's a learning curve. Like I said, I did it for a whole year, once a week for a year, and it didn't sink in until 3 months later. So Heather and Justin are starting to pick up the DBS, which is helping to fill the gaps in my clinic specifically, because I was personally not able to see that many patients at the frequency that they needed to be seen. So Justin and Heather are helping to fill those gaps along with Robert to help. Okay, so we talked about the two different brands, so we'll start with who is a candidate for DBS. So DBS is approved for 3+ diagnoses. I'll focus on the movement disorders one. So Parkinson's disease, obviously, essential tremor, and dystonia. Sorry, I have a typo there. And it's also approved for obsessive compulsive disorder, but we're not going to go into that now. There are some other requirements to be a candidate for DBS. You have to have had your diagnosis for at least 4 years. You have to be less than 80 years old. You cannot have any major cognitive impairment, and to prove that, you have to undergo formal neuropsychiatric cognitive testing.
Priya, we can't see your screen.
Oh my gosh, I'm sorry. Here we go. Okay, sorry.
There's a lot of technology going on today.
Yeah, like it's a bit much for me. Okay, can you see my screen now?
Yes.
Okay. So yes, you have to have a relatively healthy looking MRI of your brain, because if you have a lot of age-related wear and tear, or you have bleeding on the brain, that's not a healthy brain that you want to have a surgical instrumentation going into that. And you have to be levodopa responsive. This means that you have to be someone for whom carbidopa-levodopa makes a clinical response and a clinical effect on your symptoms. And to prove that, we have to do what is called a medication challenge visit. Okay, so why do we have these requirements? So first of all, you have to have your diagnosis for at least 4 years. The reason for that is because if you have a Parkinson plus syndrome, such as dementia with Lewy body, multiple systems atrophy, progressive supranuclear palsy, one of the like cousins of Parkinson's, usually that will present itself within the first 4 years. And those patients are not good candidates for DBS because their syndrome and their disease process will be much more severe and quicker, and the benefit there is not going to be greater than the risk. So we wait that 4 years. Within 4 years, if you have not presented with any of the syndromes of a Parkinson plus syndrome, then it's most likely just garden variety regular Parkinson's disease. You have to be less than 80 years old. This is the suggested age outcome based on data that was gathered. Like, people over 80 years old having this are going to have poorer outcomes. The risk at this point is greater than the potential benefit, and they're not probably going to have enough of a time course to really benefit from all of the risks of having neurosurgery. You cannot have any major cognitive impairment. So to prove this, you have to go through formal cognitive testing through one of our folks down at the Neuropsychology Center. Usually it'll be Dr. Natalie Sherry or Dr. Luke Henry, or one of the fellows if they're doing teaching that day. This is a comprehensive cognitive evaluation. It's about 3 or 4 hours where they test short-term, long-term memory, problem-solving skills, visuospatial, language, rote memory. So a lot of stuff goes into this. It deep dives way back into like your childhood. Anything that has happened in your life somehow emerges on here. And the reason this is important is because, yes, we need to know if you have cognitive impairment to begin with, because those patients have a high probability of having a poor outcome from DBS. So notice I did not say you're not a candidate. It's that you have a higher chance of your cognition worsening after, again, which would outweigh any potential benefit. The other important thing that I gather from cognitive testing is whether a patient also has any other degree of depression, anxiety, mood disorders, obsessive compulsive tendencies, because I'm very comprehensive and holistic. I like those things to be under control prior to going for a DBS surgery. In fact, uncontrolled anxiety or depression are exclusion criteria. So if you have depression or anxiety, that has to be well controlled prior to surgery, because if you're an anxious person and you go through brain surgery, your anxiety is obviously just going to worsen. It's going to impede the programming afterwards. It impedes your ability to reliably communicate feedback regarding your symptoms. And we need somebody to be controlled in those aspects to be able to tell us how they do with programming, because we do programming in the office, but then you go home and your homework is to observe how your symptoms have changed, improved, worsened, and if you're so anxious that you can't really pay attention to those things, that doesn't really help us. The cognitive impairment also helps us if we are in between. There are 2 sites that you can stimulate in the brain, and there's another picture that'll show this, but one of the sites is kind of the more common site. However, if a patient has a mild degree of cognitive impairment, we tend to pick another site that has a lower chance of worsening that. So it helps us guide our management as well. You have to have a relatively healthy looking brain. So there is a condition called vascular Parkinsonism, which means you look like you have Parkinson's disease, but the cause is because of a lot of age-related wear and tear in the parts of the brain that control movement. So these patients can look just like regular Parkinson's disease, but the trick is that they don't always respond well to carbidopa levodopa. So that's part of the next step, which is the medication challenge visit, is to prove that somebody is a good candidate for DBS. So basically, whatever levodopa does, DBS does the same thing, but more powerfully, more effectively, more adjustably, with fewer side effects. So you do need to prove that the patient at least did have some benefit with levodopa. And you also have to prove that it's not something like vascular Parkinsonism, which looks clinically just like Parkinson's disease, but patients don't have a good levodopa response. So those patients would not be a good candidate for surgery. There are other patients who have had a lot of hemorrhages on their brain or small bleeds everywhere. So again, not a good candidate. You don't want to be poking through brain tissue that's delicate or friable, and you have a higher chance of having a bad outcome. Okay, so how do we prove this levodopa medication challenge visit? What does this really mean? So many of you have had this with me, or you have it scheduled. So the UPDRS is the United Parkinson's Disease Rating Scale. it's kind of a general scale that tests things like speech, tremors, speed of movements, stiffness, rigidity, and walking and gait. Each of these items will get a score of 0 to 4. 0 means you have no abnormal symptoms. For example, speech is completely normal. 4 would be that you have a very severe difficulty with speaking. People cannot understand you because of the Parkinson's disease. Again, for example, here, finger tapping. So it's when I ask a patient to tap their first 2 fingers. A score of 0 is normal. 4 means you're barely able to perform the task. So you go through all of these. So basically, you have a patient hold their medication. So I usually try to ask people to hold medications for at least 12 hours. I try to get people in the morning and say, take your nighttime dose of medications the day before, but don't take anything the morning of your visit. You come in, we do this score, this exam, then you take your medications in the room. You sit for about 40-45 minutes until your medications kick in into your on state, and then we repeat the score. We are supposed to show a 35% reduction of symptoms of your score to prove that a patient is a levodopa responder. However, there's some caveats to this. For example, tremor, as you see here, tremor can give you up to 20 points. So face tremor, hands, legs, feet. So you can get a lot of points for it, and you can lose a lot of points if your tremor responds to medication. But the opposite is also true. Many Parkinson's patients have a medication refractory tremor. So you get a lot of points per tremor, but after you take your medicine, those points don't go away. They're still there. So that's a caveat. There are also patients who don't have any tremor at all, so they don't even get any of these points to start with, but their symptoms are more down here for bradykinesia, stiffness, rigidity, freezing of gait. And gait is kind of underrepresented, which is ironic because I think gait is really the most important thing I'm trying to preserve for my patients is walking and independence, but gait only gets like 4 points. So this isn't like a be all end all, if you don't make the numbers, you don't count kind of thing. It's just one of the ingredients that we look for to show that, yes, this patient is likely a candidate or not. The things it does not take into account is, again, tremor, lack of tremor, or refractory tremor. And it also does not take into account dyskinesias. So dyskinesias are when you get extra movements because your medication has a high level in your blood. You get the benefits, but you also get the extra side effect of like too much movement. And that is, again, another point that goes in your bucket towards being a candidate for DBS is if you need so much medication to keep you in your on state that it's also contributing to dyskinesias, that can be a helpful indicator that this patient is a good candidate for DBS, but you don't get any points for or against that. So just something else to be aware of. Okay, so myths. If you're my patient and I think you're a candidate for DBS, I will bring it up to you from the first visit. Usually the way I know that is if you're coming to me to start with and you're already meeting all the criteria, I'll start to bring it up because the first time you hear it, it sounds horrible and crazy. The second time you hear it, it doesn't sound so bad. And then the third time you hear it, you're like, yeah, let's go for that. So I kind of bring it up repeatedly to lessen the dramatic sounding nature of it. But a lot of the myths that I hear from patients are kind of based on old information. So in the past, DBS was considered like a last resort. Like you've tried everything, you've done all the medications, you still are not feeling good, you're still having bothersome symptoms. So okay, finally I can get DBS. Another myth is I'm not bad enough. So I have to be really bad. I have to be on a ton of medications. I have to look really stiff and slow, and I have to have a really bad tremor. Again, not true. So these are not true because DBS is a really powerful and effective tool. I kind of explain it to patients like your body's like a car. It's easier to maintain it and run it and like put the gas in and put the oil in and get the maintenance checks and keep running it, as opposed to like letting it sit in the garage, don't do any of the maintenance work, and then it kind of deteriorates and things get rusty, and then you take it to the shop and just put it in new oil and new gas and then try to run it. It's not going to run as good. Whereas on the opposite side, if you gave it all the tools, you gave it all the fuel it needed from the beginning and kept on maintaining, it's easier, it'll run longer and better and more efficiently. So I don't think patients need to be bad enough. They actually need to be good enough that I have something to preserve and I have some kind of goal to say, well, you look good now with medicine. Let's put some other tool in now while you still look good so that you can continue to exercise and keep your body conditioned so the effects of your disease process will be mitigated on your body. The other myth is that it's only for tremor. Not true. It's good for stiffness, bradykinesia, freezing of gait, and tremor as well, and also good for medication reduction if you are having so many meds on board that you have like more side effect than benefit, or those side effect benefits starting to be equal to each other. That's a good indication as well. Okay, so target sites. So these electrodes go down into the brain. We discussed the two common ones for Parkinson's disease, STN, subthalamic nucleus, and GPI, globus pallidus internus. You don't really need to be too aware of these. This is more for you and your doctor to kind of figure out depending on what symptoms you have. STN is the more common one. This is where you program in the office and you get immediate results. Like you can see right away a tremor gets better, freezing of gait gets better, speed gets faster. GPI is a little bit slower, but again, good for people who may be on that cognitive impairment spectrum, and we don't want that to get worse, but we still do need to do something more proactive for their PD. The GPI is then a good target. This is good for people who have a lot of rigidity, bradykinesia, and stiffness. STN is good for reducing medication burden. GPI, good for reducing the risk of progressing cognitive impairment. So again, these are all little caveats that your doctor would discuss with you and choose. Okay, so what can improve? Tremor, bradykinesia, which means slowness, freezing of gait, which is when you stand up or you start to walk, your feet are stuck to the floor, shuffling, stiffness, and then this one is tough, balance. Everyone always asks, is my balance going to get better? So yes, but no. It's not going to inherently magically get better. If you are off balance because you have dyskinesias, you're moving too much extra, it's causing you to feel off balance. If you have balance issues because you have so much stiffness and one side is way more stiff than the other side and you're off balance because of that, then yes, that can improve. If you have balance issues because you're really having freezing of gait or shuffling and that gets better and then you're able to walk better and improve your balance, yes, indirectly your balance will improve, but not just with the click of one button, you're on balance all the time. Okay, so the things that can worsen, again, balance can technically worsen depending on the sites of the implantation. So typically for Parkinson's disease, those two sites do not worsen balance. It's more for patients who have essential tremor and they have a different site that's targeted bilaterally. Your balance can technically worsen with that. Keeping in mind, there's also, if you're in the age group of people who are having this, you may also already have some wear and tear on your brain and you may have already had some balance issues to begin with. So we don't want to like blame everything on the DBS, but you have to just take that into consideration. And then cognition. So cognition can worsen. Again, if a patient already has mild to moderate cognitive impairment on the cognitive testing, bilateral STN can technically worsen this. So sometimes we choose the other side of the GPI to mitigate that. And I have an asterisk here because cognition is a little tough. If a patient has really bad anxiety because they have such poor control of their Parkinson's symptoms and they have wearing off and they get anxious and they get really stressed about it and all they think about with their brain is like, when is it time to take meds and how am I going to do today? Is it going to be a good day or a bad day? If that is causing their perceived cognitive issues, that can maybe improve if we get symptoms under control, less dependency on medication, less side effect of medication, less interaction of medications with each other that can cause side effects. Maybe their cognition can indirectly improve. So I put an asterisk by that for a reason. So that's what the cognitive testing is really helpful for, is to find out if a patient really has true cognitive impairment or is it sort of pseudo cognitive impairment due to anxiety or depression or another mood issue. Okay, what are the goals of DBS? Goals include improved quality of life. One major goal is to reduce medications. DBS is a good category, a good option for people who are taking lots of medications throughout the day. They have to constantly be checking the watch, say, is it time for this? Is it time for that? Medications are not always lasting the time period that they're supposed to last. The more and more meds you add, the more they interact with each other with possible side effects. Dyskinesias can increase as your disease progresses and as medications are added. So that can be a goal, is to reduce these side effects and reduce the dependency on medications. Reduced off time. So off time is when your medication is worn off and your Parkinson's disease symptoms are at your worst. It could include freezing of gait, worsening tremor, but also some other non-visible symptoms such as shortness of breath, impending sensation of doom, anxiety, slowness of thinking. So you want to reduce that and keep people in their on state as much as possible. So that can be a goal for your DBS. Freezing of gait is a big one too. So freezing of gait it's my pet peeve. It's only there for a few seconds, but it can make the difference between getting up and walking or getting up and falling. And those are two huge differences. It doesn't always happen just when you get up. It can also happen like when you're crossing a threshold or you're going from an open space to a smaller space. And that's just my biggest pet peeve is falls. So if there's anything I can do to reduce falls, reduce risk of falls for patients, I try to do that. Okay, thank you everyone for joining. That's all I have for today, because today is just the beginning part of what happens before DBS. My next lecture is going to be more specific about the actual procedure itself and the surgical procedure and the day of. And then after that is going to be my lecture on how we go about programming after. So,
Thank you, Dr. Cardone.
thank you. So,
There's a few questions.
Okay, potential changes in speech. Yes, that is a possibility. So that is more for when we are actually doing the programming. You will know about side effects in real time. While we are doing your programming, we are repeatedly testing speech, a couple of movements, and visualizing the patient. So if the patient has a side effect of speech change after we put on a setting, we change a setting, and then their speech gets slurred or tight, we just back that off and that goes away. In regards to, so that's one of the things about speech. The other thing that can improve is like voice quality. So I have a lot of patients who, once we turn on their programming, we find some specific settings, their voice is a little bit stronger, there's less of like mumbling, and they're just able to talk louder. Of course, there will always be a potential side effect of speech worsening, but I have not actually seen that anywhere so far. And if I do, it's more related to like a cognitive change. So yeah, or it's because of a programming side effect, which we would just undo in real time. We would never let a patient go home with speech side effects.
Thanks. Does anyone have any additional questions? We have a few minutes.
Sorry, I'm talking really fast because I'm trying to get in all the information as best as I could. So, but it'll be on YouTube after, so you can watch it again.
This has been very helpful. And there's more to come.
There is.
In October and November.
Yeah, it's a big topic for DBS, so I needed 3 months in a row.
And it was nice to have Medtronic and Boston Scientific join.
I agree. Thank you both so much, Adam and Chris, for taking your time out of your day too.
And there's a third manufacturer, Abbott.
Right.
So options.
Yes, there are options.
I have a question for Adam. I understand that with the adaptive technology, it can kind of go to sleep when your brain waves are not active, like when you're sleeping. Has that ever resulted in a problem if you have to get up in the middle of the night and go to the bathroom, for instance?
That's a really good question. Before I give my answer, I would just, offer that to Dr. Cardone from her expertise.
Okay, yeah, no, it doesn't ever turn off 100%. So we always have a parameter. Like you can never drop below the parameter we set. You can never go higher than the parameter that we set. So if you're sleeping and your symptoms are not active, which is normal for Parkinson's disease, you would drop.
We need your microphone.
Sorry. Okay, so no, it doesn't go to sleep. It doesn't like turn off or anything. You can only go as low as we allow it to go. Like, so we will set a bottom limit, we will set a top limit. You can never go above or below that. So it never turns off. If you're sleeping and your symptoms are under control, which they normally are, symptoms disappear during sleep, you would drop to the bottom of your level, your settings. But if you wake up, you would have that spike in symptoms again, potentially, and it would turn, it would adjust up or down, but you will always stay within the parameters. You'll never be off completely.
Thank
So
you.
that's actually one of my selling points for DBS is that it's 24 hours a day. So even when you're sleeping, you still have some symptom control because patients in this age group tend to get up and go to the bathroom overnight. So one of my questions in the clinic is, are you someone who gets up and goes to the bathroom overnight? Is your walking at night worse than your walking during the day when you're unmedicated? And is that a fall risk? Yes. So DBS is a good solution for that. But I will also defer to Adam if he has any extra information.
Basically everything that Dr. Cardone just said, but also the idea of how quickly and how slowly it adapts is something we consider very specifically per patient. And when you get up to walk, we have a mode that adapts really quickly. We have a mode that adapts really slowly. So maybe if, we have tried one version or the other and getting up to walk is easier on one versus the other, we would potentially leave you in that one. There's lots of complexities and interesting things to this, but the good thing is it's all about options and using them effectively. So good question, though. I like that one a lot because that's something our patients who actually have DBS and are having adaptive turned on ask quite often is, what happens if I have to get up suddenly? And yeah, thank you.
Okay, anything else?
I have another one, but I don't want to waste time if nobody's interested. But
You're
I'm
good.
just curious, like what happens if the leads move?
I'll leave that for Chris and Adam. I have never had anybody who's had that.
Yeah, so the only time I've seen leads move is with significant trauma to the body in some way where actually like caused a major fall, major accident, something like that. And they have in those instances, which are very rare, gone back in and just repositioned the lead. Either literally they just loosen the hardware and move it back down to where it was, or, God forbid, they have to take it out and replace it entirely. But that's kind of another beautiful thing about deep brain stimulation is, although more surgery is not fun, things like that, what we can say is that it is reversible because you can have it taken out, and then you can also have it serviced if something like that did happen. Good question.
Yes, I would agree with Adam as well. We don't see the leads move very often. The only time I have seen leads move again was car accident, something that was kind of a tragic accident, something like that. Completely agree with Adam on that one.
Okay, one last question. We're seeing all sorts of things come that are in trial that seem to be pretty effective thus far, like stem cell therapy or gene therapy. And I believe you are disqualified from having those procedures if you've had DBS. Is that true?
I don't know that actually. I don't know the answer to that, so I'll look it up.
Oh, we need the mic.
Sorry, I don't know the answer to that. I'm sorry. I will have to look that up unless if Chris or Adam know anything about it.
I can say for us, for Medtronic, and I pretty sure it's the same thing for Boston and Abbott. Is there's not anything in our labeling that says anybody who has had any type of gene therapy is disqualified from or not a candidate for or contraindicated for deep brain stimulation. Yeah.
Yeah, I think it goes the other way. I think gene therapy and STEM therapy may be saying if you've had it, you don't qualify. So
I
if
will,
anyone on the
yeah.
call is considering that, I just want to point that out.
I will also ask my colleagues about that. There's another question. How long can it last in years for controlling PD? I'm sorry, I must have forgotten to mention. This is good for the rest of your life. It's in there, it's permanent. It can be adjusted indefinitely with a basically infinite number of combination of settings because there's 3 parameters on each side, multiple different programming settings. So basically like an infinite number of combinations of settings. So as and when disease changes, symptoms progress or change, we just adjust and adjust and adjust indefinitely.
And I can share, Casey and I have a colleague who had a family member who had DBS, and she lived with Parkinson's for 30 years and of course was very advanced at the end. And she had an early version of Medtronic and needed to have a battery replaced. And it was only when that was turned off that she realized how much help she was still getting from it. So the disease continues to advance, but it still works for your life.
Yeah, and we see that in the clinic all the time. When you come in for your programming visits, when we check some of the parameters, it turns it off for about like 30 seconds. And in that time, sometimes people see symptoms that they never even knew that they had, like tremors or stiffness or, just any other dystonic posturing, and they didn't even know they would have had that except for that it was turned off for like 30 seconds to check.
I just thought of one last question, but if someone else has one, let me know. I don't want to keep you too long. What would you say the average number of adjustments takes place after the initial procedure?
So I have a pretty standard protocol. You get the brain implants in, then you wait 6 weeks because you have what's called the micro lesion effect. So your symptoms all disappear for 6 weeks. And it's like you don't have Parkinson's. And so we don't do any programming then because we don't have anything to monitor. So 6 weeks later, you get your first programming visit, which is about 90 minutes. Then every month for 3 months. Then we switch to every 3 months for 3 to 6 months. And then, depending on that particular patient, how fluctuating their symptoms are, every 3 to 6 months. So multiple times per year, indefinitely.
Thank you. Well, more to come. We'll see you in October. Thank you, Dr. Cardone, and thank you to Chris and Matt for joining.
Chris and Adam.
Chris, yes. Chris and Adam, thank you both.
Thank you. Thanks, everyone.
Bye for now.
Okay.
Great info. Thank
Yes,
you.
Thank you.
For sure.
Bye-bye.
Bye.